I forgot to mention I'm part of a few clinical trials as a local principal investigator with either grant funding or a couple of companies as listed here on this slide. So we like to start with a little bit of background information, which hopefully is fairly familiar to most people here. And I like to just start with this, even in my own slide sets, to place into context why we think that this topic is important. So we know that in the general population, the annual incidence of VTE is approximately 1 in 1,000, making it the third most common cardiovascular disease after heart attack and stroke. Cancer itself can increase the risk of this by about 4-fold on average, though we do know that some cancers are more thrombogenic than others, and I'll go over that in the next few slides. Chemotherapy can add additional risk to this, and again, different chemotherapy regimens will have different thrombotic risk, but as a general rule of thumb, in addition to cancer, chemotherapy will increase the 4-fold risk to a 6.5-fold risk over the general population. And if you multiply these risks together, we get an approximate yield of about 1 in 200 cancer patients per year getting a venous thromboembolic event. And I think we can all know that this is probably a pretty good estimate. We probably all have at least several hundred to several thousand patients a year coming through cancer centers, depending on how big the local center is. And we most certainly have a large volume of patients with clotting. And I started my clinic in 2014, and we probably get on average 6 to 7 consults a week, so about 1 a day. And so I think that does average out to roughly this statistic. So if we take a look at a cancer patient's journey through thrombosis, I think it is important to take a look at slides that look like this. This is obviously a graphical representation of a hypothetical patient, and all patients will be slightly different. But for our benign patients, we generally have a fairly flat curve. So they have their acute phase where they're very high risk. We treat them through their acute phase, and then they have a fairly stable chronic course thereafter. But for our cancer patients, you can see there are a lot of ups and downs. That red line is the generic risk for the cancer-associated population. The black line on the bottom is the risk of the general population. But the cancer patient can go up quite far above this, even the cancer risk line, if they get hospitalized or if they have progressive cancer, metastatic disease, end-of-life care. They might be able to dip a little bit lower when their cancer is in remission or potentially cured in the best-case scenario, where they may be a bit closer to the general population risk, although they may never decline back to that state. We know that this is important because when we're trying to pick the best therapy for our patients, it does depend on how thrombogenic they happen to be at any given time and whether there's other interactions such as drug interactions or metabolic interactions through their cancer course that might impact the treatment. So I think it's also important, so I was just trying to click this through, that last bit was just showing you that 6 times roughly higher risk of having a clotting event on average. And then I think it's important to recognize the demographics of cancer. So we know that the rate of actually having a thrombotic event with various cancers, and the highlighted one is just the most thrombogenic, pancreatic cancer. You can see there's a wide variety. While the overall average is around 6 times higher, you can see that some cancers are relatively low in terms of their thrombotic potential up at the top of the list, and other cancers are much higher. And the problem I find is if you try to correlate this slide with the next slide, which shows you the incidence of the different cancers that are out there, the less thrombogenic cancers in general are the more common cancers. So breast cancer, colon cancer actually have a lower incidence of clotting events than things like stomach, pancreatic, and brain cancer. Lung cancer, unfortunately, has the worst of both worlds. It is both common and thrombogenic, but I think when we're thinking of how to apply the rest of this talk, the evidence that I'll be presenting to our patients that we see every day, we do have to recognize that the most clot-producing patients and the hardest clot patients to take care of were not very well represented in any of the clinical trials on cancer-associated thrombosis, and the most common ones were the breast, lung, and colon cancer patients. So I think we probably have at least heard of these statistics, if not seen this almost exact picture from one of Dr. Krana's papers, taking a look at what kills a cancer patient. And I think we are very comfortable knowing that cancer progression is the number one thing by far. But I think a lot of times we fail to impart onto our patients that venous thromboembolism is also very important. And even as a thrombosis doctor, if I'm telling my patients about leukemia or lymphoma, it doesn't just roll off my tongue to talk about thromboembolism. I beat infectious complications into the ground for these patients. I talk about mucositis and various other things that can happen, but venous thromboembolism is not really at the forefront. And I think we do have to recognize that it is the second leading cause of death in cancer patients, and we should be a little bit more aware of how to educate our patients properly, including how to recognize the symptoms. And we certainly see a lot of patients who've been harboring symptoms that are, in retrospect, very likely TE, such as syncope or pre-syncope or shortness of breath, but they ascribe those to having chemotherapy side effects or just having cancer, and they may have diagnoses missed along the way. So I think it's important to just ingrain this picture into our head so that we know how to counsel our patients moving forward, and we know how to teach our trainees to counsel patients as well. If we look at older guidelines, this was the most recent and probably last update ever for the CHEST or ACCP guidelines on the treatment of venous thromboembolism, published in 2016, so before the major clinical trials that came out on the direct oral anticoagulants. And you can see there was a preference to use low molecular weight heparin at the time as the evidence supported that. And for the direct oral anticoagulants listed below, the level of evidence for their use was really in the realm of expert opinion. Thankfully, we've moved ahead from that point, and we'll be focusing a little bit more on the clinical trials that have come out in the last roughly year, since about December of 2017 was the first one that was presented and published, this one, and then also how that might apply to this Canadian-derived algorithm that we developed in the last half year or so. So I would like to preface this, there's no slide on it, but I would like to preface this by, sorry, someone asking a question or? No, sorry, I thought I heard a voice. By saying that there are some differences between the classic low molecular weight heparin versus warfarin trials, the CLOT and the CATCH trial, and then the current direct oral anticoagulant trials, this trial, the Hokusai trial, and later I'll present the data on the SELECT-D trial as well. And the major differences I'll highlight before I go into the specifics of these trials are that the low molecular weight heparin trials were done earlier, of course, the CLOT trial being published in 2003, where we only started to recognize the significance of accidentally found proximal blood clots in cancer patients. And so the enrollment VTEs were all symptomatically diagnosed clots in those older trials. In the CATCH trial, which was a bit more recent, they included asymptomatic and or incidentally found, the incidentally found clots not always being asymptomatic as recurrent events. But the enrollment VTE had to be symptomatically diagnosed, whereas in the direct oral anticoagulant trials, as you'll see, they accepted incidentally found clots as their enrollment diagnosis. And while we accept that the prognosis is the same for incidentally found proximal blood clots in cancer patients, I think we can all agree that the acuity of the presentation is not always the same. And the clot presentation that leads you to go to the hospital to get evaluated versus being found accidentally on a staging CT scan might not be the same. In general, the CLOT trial also, for whatever coincidental reasons, they tried to use a similar inclusion-exclusion criteria amongst all of these trials for cancer, did manage to recruit the sickest and the most advanced stage cancer patients of all of the clinical trials that have so far focused in cancer. So we always take that kind of in the back of our heads when we're comparing results and what to do with them. But if we kind of dive into our new data here, starting with the Hokusai trial, it is the first and so far only fully completed randomized control trial. The SELECT-D was a pilot trial, as we'll go over later. Primary outcome, a little bit questionably, they used a composite outcome of recurrent VTE and major bleeding throughout the duration of therapy. And I think we can kind of scratch our heads a little bit because these are opposite outcomes, clotting versus bleeding. And at least in the benign world, we know that not even evenly weighted outcomes, as major bleeding seems to have a higher case fatality for benign patients, at least compared to recurring clotting. Haven't done the similar studies yet or have as much solid evidence for these outcomes in cancer patients, but it's hard to assume that these are completely evenly weighted outcomes. But thankfully, in their secondary outcomes, which we will show in graphical format along the way, they did split out the thrombotic outcomes and the major bleeding outcomes, so we could comment a little bit more carefully what this all means. So they used the generic edoxaban regimen of starting with 5 days of low molecular weight heparin and then randomizing people or starting edoxaban, and then being on dalteparin ongoing. The edoxaban arm used 60 milligrams once a day, which is the generic dosing that we use for all patients. We'll go over in the next few slides. There were some dose adjustments made in the edoxaban arm for specific parameters, also following the benign trials. And the dalteparin arm followed the clot trial regimen with 200 units per kilogram for the first 30 days and then 150 units per kilogram thereafter. They followed patients, and the wording of it was a little bit strange, but they said they intended to treat people for 6 months, and then after 6 months, it was left up to the patient and the doctor. I have a little bit of a soapbox to stand on for that. I think we have always known that patients with active cancer have a very high risk of recurrence if they stop their treatment, and we have lots of data to suggest and support this, and to not really, in a prospective randomized trial, reinforce that patients should stay on their anticoagulation was a little bit of a sore point in my head, because as we'll see, there were consequences to coming off treatment early. So if you take a look at patient characteristics, though, they did a very good job of randomization. There was no major differences, but treatment duration, as I alluded to in the last slide, was different and statistically significantly different between the two arms, where the edoxaban arm ended up staying on for, on average, about a month longer than the dalteparin arm. If we take a look at the types of, skip one slide, the types of cancers, you can see again the most common cancers are the ones that we expected: colorectal, lung, breast, and genitourinary cancers, whereas some of the more highly thrombogenic cancers like pancreatic cancers, hematologic cancers, brain cancers, very poorly represented as an overall number in these trials. In terms of the actual chemotherapy regimens, as you'll see in this next slide, it also follows the most commonly seen cancers. So the antimetabolites and the platinum-based therapies, or the colon and lung cancer therapies, even the taxanes for breast cancer were much lower down the list. And you can see various other very important chemotherapeutic agents that we use all the time in many other cancers are 5% or less in terms of their representation in these arms, which does make it a little bit of a quandary when we're examining drug interactions and how to use these properly and safely. If you look at their primary outcome first, which was that combined endpoint of both clotting and bleeding, you can see that the lines were almost exactly overlapped. So they proved that it was non-inferior based on this combined endpoint. And also they did a superiority test, which showed it was not superior, but non-inferior at least. And they did split out the first 6 months. They split out per protocol versus intention to treat, and basically all of the outcomes when they looked at these different analyses for the primary outcome of that combined endpoint were the same. If we try to split out, though, the clotting and the bleeding events, I'll first quickly review that the last purple box. The event-free survival was no different between the two. So the cancer prognosis basically was the same, and I don't think anyone was shocked by that. But if we take a look at the recurrent VTE and the major bleeding event, this starts to dig down into how to explain these results and how to apply these to our patients. So if we look at the recurring VTE line, I know it's a little bit small on this screen, but I think we can squint a little bit and see that at the 3-month mark, prior to that, the lines were completely overlapped. And then at the 3-month mark, it seems like there was this split. It was a non-statistically significant difference, but you can clearly see that one line is recurring more than the other line, and the top line is the dalteparin arm. So there were more recurrences on low molecular weight heparin after 3 months, which begs the question of what happened at 3 months. I always like to describe this result to people by reminding you that, of course, the most active phase of clot is the first 3 months, and that's when the acute phase of the clot occurs and when the clot is healing. And then beyond that is more of the secondary prevention phase of preventing recurring thrombosis. So if one drug was truly more effective than the other, you would assume that the curve would split from day one, or at least in the first month when the risk is the highest, and not in the secondary prevention phase. And so we're going to try to look a little bit closer at that curve, but I can say that it's very likely that patients were coming off treatment. And we did again see that there were more patients who stopped dalteparin compared to edoxaban throughout the course of this trial. And consequences were recurring VTE, so obviously not a good thing. For a major bleeding perspective, you can see, again, squinting a little bit, but you can fairly clearly see even on this small graph that the curve split from day one, and there was certainly more major bleeding events on the edoxaban arm this time compared to the dalteparin arm. And this was statistically significant, and we're going to delve a little bit into who was bleeding and how that might impact our treatment decisions. So if we take a look at the types of bleeding that occurred, I don't think from a type of bleeding perspective people were surprised that the major bleeding events is very similar to benign trials, the ones that we worried about the most, and the most common ones were GI bleeding and intracranial hemorrhage, one being the most severe and the other being the most common. But there is certainly a big difference between edoxaban and dalteparin in terms of how many people had upper GI bleeding. And you can see that the vast majority of the results that showed a safety benefit to dalteparin fell into the upper GI bleeding category, and we'll kind of dig further into that as well. The bottom part of this table shows this score that I'll admit is something that we pondered a lot in our group when we came up with our Canadian consensus algorithm, what to do with this index of severity. And I had to actually look back to figure out where this came from because I had never seen it used in a clinical trial before. And digging back to where they actually came up with this score, it was in the rivaroxaban benign trial initially, but they also applied this to apixaban and I believe also edoxaban later. But it was post hoc applied. So the investigators made a score that tried to describe the severity of major bleeding. So I would like to highlight this is not any bleeding. This is the entire major bleeding category. And to try to classify, again, with a tool that they made up for that study and not prospectively validated, to differentiate between the severity of bleeding within the major bleeding category. And then they actually had a second part to this score, which was the clinical course that also was a 4-point scale. And I get the impression that they were trying to show in the benign trials that if you had, for example, intracranial hemorrhage on warfarin versus DOAC, that the clinical course, even though the severity of the presentation would be the same, the clinical course would be worse in warfarin, probably because half-life is longer or however you want to explain it. And I think that was the original intent of this score, to show that major bleeding events are not all the same between different anticoagulants. So it's a little bit odd that they used this in a prospective randomized trial without previous validation of it, and they only presented half the score, so we don't even have the other half. I don't even know if they collected data on the other half. So it's very hard, and we found it difficult to know what to do with this score, and as you will see when you have a chance to read the paper, if you haven't already, on our algorithm, we don't really talk a lot about this severity of bleeding because it's difficult to kind of split hairs in the major bleeding category. But I'll leave it up to you, and if you have more questions later or now, I can certainly sift through them, but we chose largely to ignore this part in our algorithm. If you take a look at some of these other key points, I mentioned a few of these, but I always like to reiterate them. The duration of treatment was different, and it was statistically significantly lower in the dalteparin arm, which probably explained the split in the curve. It could also suggest that compliance-wise, it's easier to maintain a patient on an oral anticoagulant versus a needle. That could very potentially be true and is still an advantage to an oral agent. But I think it also still highlights that we should counsel our patients a bit more severely to stay on an anticoagulant of some kind to prevent recurrent events. If we take a look at who was bleeding, it was really the GI cancer patients who had the vast majority of the bleeding events. And it was really, they lumped all the GI cancers together. So colon cancer, upper GI cancers, hepatobiliary cancers, pancreatic cancers, all of these are put into that category and showed that there was clearly a much higher rate of upper GI bleeding specifically in those patients on edoxaban versus dalteparin. Not shown on this slide, but certainly shown in our algorithm as well as in the original paper. Another category of patients who had a very similar split, almost the exact same numbers between edoxaban and dalteparin, was the urothelial cancer patients as well. And they ended up having major bladder bleeding events or hematuria. And there is something about, we think, these hollow organs that seem to have some bleeding disadvantage to maybe not across the board all of the direct anticoagulants, but there are these signals that have come out both in these cancer trials, in the benign trials. Some of the direct anticoagulants had a higher GI bleeding rate compared to warfarin. Apixaban and rivaroxaban have published some data on menorrhagia compared to warfarin, showing a higher rate of menorrhagia. So we're not really sure what it is about these kind of mucous membrane-lined hollowed organs, but something about them seems to suggest that there may be a safety difference between between different anticoagulants. And we definitely saw that in these cancer patients. And unfortunately, GI cancer is one of the most common cancers, and so it's not a small thing to shrug off. If we take a look at, sorry, I'm just clicking this, move the slide. Oops, clicked twice by accident. If we take a look at some of these other potential limitations to this trial, I don't know if this first point is a limitation, but it is certainly a caution when you're interpreting how to use drugs and whether or not you can apply class effect. I know a lot of us like to pretend that all the direct oral anticoagulants are the same, but I think we should be cautious about this, particularly in very complex patients, which may have a lot of things at play. Edoxaban is, to this date, the only direct oral anticoagulant, both in benign and cancer trials, to have a dose reduction parameter in the acute phase of VTE. So I see a lot of dosing mistakes made in my center and in the literature, unfortunately, everywhere in the world, where people are not dosing the oral anticoagulants correctly in the acute phase or chronic phase, to be honest, of VTE or atrial fibrillation either. But I think one of the most common mistakes is to dose reduce based on atrial fibrillation data and not doing the appropriate acute phase dosing. Edoxaban did actually have some parameters, but it was not everybody. It was very specific parameters, as you can see here, that led to a dose reduction to 30 milligrams. None of the other oral anticoagulants had that in cancer or non-cancer trials. The dose exposure, as we mentioned a few times, was shorter in the dalteparin arm. And then certainly it does not include all of the anti-cancer therapies that we see frequently in day-to-day practice. So if we kind of compare how those results came about compared to the SELECT-D trial, I think we'll see some similarities, and then we'll also see other things that may need to be questioned. SELECT-D was a pilot trial, so I'll mention a few of the methodologic issues that occurred in the SELECT-D trial so that we know how to interpret this data properly. But as a pilot trial, it was not powered, of course, to find as much information as the Hokusai Edoxaban trial. This one compared rivaroxaban to dalteparin. Rivaroxaban was used at the same dose as we would classically use in benign patients, 15 milligrams twice a day for 21 days, followed by 20 milligrams once a day. And dalteparin was used, again, as a clot trial regimen, 200 units per kilogram for 30 days, and then 150 units per kilogram thereafter. They originally had planned a second randomization at 6 months, and this blows my mind, that they would randomize people to placebo. Again, I don't think people recognize for some reason or another that patients with active cancer have a very high risk ongoing of clot. But maybe the investigators didn't recognize this, but clearly other people did because they could not enroll enough patients into this arm. I don't know why, but I suspect that people were uncomfortable with a placebo arm, and they actually could not do this second randomization, and they had to close that part of the trial. But the original part, the first 6 months, I think is still very relevant to the acute treatment of VTE, so we'll go over those results. Sorry, I keep clicking this a little bit too vigorously. So you can see that the primary outcomes, this time they did not do a combined endpoint, which is great. They split out the bleeding and the clotting outcomes. The one thing that was a little bit of a problem that we questioned a bit was that, oddly, despite this being a randomized prospective trial, they did not have upfront central adjudication of all of their events, which is a little odd. And they decided to do that adjudication after the trial was finished, which is, again, probably not the most methodologically correct thing to do. If we take a look at other things that contributed to potential issues with analyzing the data, as I mentioned, they couldn't recruit enough patients into their second round. So they actually, halfway through, got rid of that second randomization and recalculated their sample size to be lower than what they originally had planned to do. Also, approximately halfway through the trial, they decided that there was an excessive amount of upper GI bleeding, very similarly seen in Hokusai trial, but this trial decided to start excluding at least the upper GI cancer patients from entering the trial, which for good or bad reasons, it actually probably unfairly, if you want to think about it, favored the side that was having this problem, which was the direct anticoagulant side again. So again, methodologically, maybe a bit questionable. If we take a look at baseline characteristics, the baseline characteristics of this trial, again, very similar, split between the two arms, so nothing really exciting in terms of an unbalanced trial. As I mentioned earlier, the incidental blood clots were included in this. The SELECT-D trial had 50% of their initial clots as incidental PE. The Hokusai trial, I don't think it showed up on the slide, but it had about 30% of patients had an incidental clot as their initiating event. So the final results, which I also show in graphical format in the next few slides, did show that from a recurring VTE perspective, there again seemed to be a favoring to the direct oral anticoagulant. Major bleeding, again, favored dalteparin, and really all forms of bleeding favored the dalteparin arm. And we'll kind of see this in the next graphs, as well as try to explain what's going on. So very similar to the Hokusai trial, but possibly for different reasons. Hard to say. They didn't have a lot of long-term compliance data. Again, as a pilot trial, there's just less information to dig out for SELECT-D. But you can see that the curves again split later in the treatment and not upfront. So I still make the argument that if one drug was better than the other, we should see that split happen much earlier. And so I wonder about compliance, but it's hard to say. There may be other explanations. So I'm just going to go back to this slide. There may be other explanations. In this slide deck, I don't think they show the actual table, but if you take a look at the SELECT-D actual paper, they list out what the recurrent events were. And the symptomatically diagnosed recurrent events were the exact same number between the two arms, but the incidentally found recurrences on staging CT scans was significantly higher on the dalteparin arm, and that made up this split in the curve, was all these incidentally found PEs. And while incidentally found PEs certainly happen, even in follow-up, because there's no primary adjudication for all these events at the beginning, it just calls into question how these things were diagnosed and whether there was some kind of bias between the two arms, because it seems a bit odd. Really no other study has showed a signal for any anticoagulant in cancer that you'd have a shockingly high rate of incidentally found blood clots. So it was kind of a little bit bizarre. But that made up this split in the curve. From a bleeding perspective, again, you can see that the events start splitting very early in the trial in favor of dalteparin for safety, and there's more major bleeding events in the rivaroxaban arm. Most of those were upper GI bleeding again. There was also urothelial cancer patients with hematuria that made up some of that curve as well. So the split of bleeding was the same between the Hokusai trial and the SELECT. Major limitations of this trial was that it was a pilot study, so with all those methodologic concerns I mentioned, I think it is a pilot trial, so it wasn't really designed to be as rigorous as Hokusai. They did, again, have these issues along the way where they had to adjust their protocol, which may or may not have made a difference to their results. If we did a systematic review, I think this was actually done fairly recently to take a look. There's only two trials, so there's not a lot of data to systematically review. But if we take a look at what's happening here, again, a slight favoring from an efficacy perspective, but with all those caveats I mentioned earlier, in favor of the direct oral anticoagulants, and for major bleeding, a favoring towards low molecular weight heparin for safety. I think one thing that, again, is worthwhile to dig through some of the papers to take a look is, while GI and GU cancer patients were brought up as a cancer type that was very dangerous from a bleeding perspective, in the Hokusai trial, in one of the 35 pages of their supplemental appendices, there's also a nice table that shows a few of the pre-specified bleeding risk factors that they randomized to be even between the two groups. And the more and more of those risk factors, which included the type of cancer, but also included very common things like renal failure, thrombocytopenia, concurrent use of aspirin, recent surgery, and so forth, just common bleeding risk factors that we all accept are real. The more and more of those risk factors you had, with or without GI cancer, it favored dalteparin in terms of safety. Hard to know why, but it could just be that maybe the drug is inherently safer for some patients, or maybe it's more titratable and more adjustable because it's a liquid and not a pill. Hard to say, but certainly for very, very complex patients with a lot of risk factors, there also seemed to be a favoring from a safety perspective towards low molecular weight heparin. So one thing that I think is very important that we should always think about, and my oncologists in my center feel that this is biggest thing, the biggest problem with the direct oral anticoagulants that they're very nervous about, is the drug-to-drug interactions. We were spoiled in the day of low molecular weight heparin, where we basically had to worry about nothing, and we could put a patient on any anti-cancer therapy, including clinical trials and new drugs, and not have to worry that it interfered with the low molecular weight heparin or vice versa. If we take a look at the oral anticoagulants, including warfarin, or other vitamin K antagonists, there are obviously major enzymes in the liver that process all sorts of drugs, including the chemotherapies we use, that are affected in some way, shape, or form. And unfortunately, the one with the least number of interactions is dabigatran, but dabigatran has obviously a much higher rate of GI bleeding, even in benign patients due to its formulation. And if GI bleeding is a thing we're worrying about, I don't know if that's the answer. And there are currently no ongoing, as far as I know, dabigatran-specific cancer-associated thrombosis studies. So I think dabigatran may not enter that arena regardless. But you can see that there are multiple drug interactions or potential drug interactions that we need to worry about for these medications. This certainly is not a complete list, but it does give us an idea that very common drugs that we use, the sidebar is more related to all these increasing number. Every day there's a new one for tyrosine kinase inhibitors, but certainly even some of the more common chemotherapeutic agents on the other side of the slide do have interactions with a lot of these enzymes. The problem, I think, is that we can attempt to make a list, but probably every couple months we're going to have to add new drugs to that list. We're never going to know what the clinical trials are going to come up with and what drug interactions are going to be new. We know that a cancer patient is very similar to that one of the first slides I showed. Their clinical course changes. It's not a steady amount of drug like benign patients where they take the same medications forever. A cancer patient has, first of all, the chemotherapy is cyclical, so it's not every day that they take the same drug. So interactions may be changing week to week. They have dose increases, dose reductions based on toxicity. They sometimes add in medications, or they change the entire therapy if it's not working. And on a semi-regular basis for a lot of patients, they may get chemotherapy breaks. They may have radiation or surgery in between and then go back on a different regimen. So the landscape keeps changing, and this is not even including their supportive care, which is the anti-nausea, anti-pain, antibiotics, and all the other anti-drugs that have multiple drug interactions as well. So we're stuck in a very bad situation where we always have to think about these drug interactions for the oral medications. And in the realm and the times of warfarin, we could at least see what we were doing. It was bad, and the time in therapeutic range was not good, and we don't like to use warfarin in cancer patients for a number of reasons, including that one. But at least we could kind of see the impact of the chemotherapies on our anticoagulants. Whereas these newer drugs, we unfortunately don't have that ability to monitor them the same way. So it's a little bit of a shot in the dark for some of the agents. I always recommend that people should probably have a good conversation with their cancer pharmacist if they're unsure, and certainly if there are so many medications that you don't know and there are multiple interactions within the same drug regimen, you'll never be wrong to choose low molecular weight heparin first and think about it later when you have a little bit more information. Other factors we always like to consider, and we did talk a little bit about this in paragraph format within the paper that supports the algorithm that was recently published, is the burden of cancer, the burden of the clot itself. I alluded a little bit to how much of the burden of cancer and clot may have varied between trial to trial. They're all active cancer patients, so none of them were kind of non-active, but certainly some trials enrolled more active and more sick patients, and some trials had a bigger split of sicker and more symptomatic clots. But all of the trials excluded patients who needed thrombolysis or other extreme measures to remove clot, and I think even in the benign world, we're much more comfortable using some kind of parenteral therapy at the beginning when a patient is hospitalized for possible thrombolysis than to skip down to direct oral anticoagulants right away. Renal failure patients, still an ongoing quandary. We have increasing data on what to do with low molecular weight heparin. It's starting, in the benign world at least, for the direct oral anticoagulants, but we don't have a lot of information, and so certainly the severely renally impaired patients, particularly additionally have other risk factors like cancer and thrombocytopenia and various other things. I think we're probably a lot more comfortable using low molecular weight heparin than another drug. Clearly common sense, if you can't absorb the medication for whatever reasons, your GI tract is non-functional, you have severe mucositis, you're having nausea, vomiting, cachexia, is important to avoid oral medications in those situations. Extremes of body weight, while we focus a lot on overweight patients, I think underweight patients we should think about as well. So patients who are under 50 kilograms, for example. We don't have a lot of data on what happens to patients with these medications either. There are some suggestions, including from the International Society of Thrombosis and Hemostasis, that we should consider avoiding these direct anticoagulants when a patient is over 120 to 40 kilograms. You kind of pick a target, not because we know that they don't work, but because there's possibly some suggestion in early pharmacokinetic studies that there might be less drug. We don't know if clinically that makes a difference, but there may be less drug concentration in the very overweight patients and maybe more drug concentration in the very underweight patients. So things that we unfortunately have to think about. And low molecular weight heparin, again, because it's liquid and weight adjusted, can be titrated based on a patient's weight, and it may be easier to and more malleable to use. And then obviously if you have other reasons not to be on these medications, there's a couple of other antithrombotics listed here, but if you have heparin-induced thrombocytopenia or something that clearly prevents you from being on a drug, then those are just other common sense things to think about. So patient preference, I think we have realized in the last little while, probably should have always known that patient preference should be considered, because no matter what we recommend to a patient, if they don't want to do it, they're not going to do it. So it is still better, even if one drug may or may not be inferior, may or may not be less or more safe. If the patient is willing to do something, it is better to be anticoagulated with an acute clot than not anticoagulated. But at the same time, I always like to remind people that I think patient preference is strongly impacted by doctor preference. And if I think personally I can convince a patient to be on any drug, at any dose, even if it's a made-up dose, if I word it to a patient like it's the greatest thing on earth. And I can also convince a patient not to take the best drug and the most effective drug if I word it in a fashion that makes it sound terrible and chock full of side effects. So I think we have to kind of take away some of our own biases when we're explaining these nuances to a patient so that they can make an appropriate choice for themselves. And I find that there are a lot of people who unfortunately will paint low molecular weight heparin as a terrible medication no one ever wants to be on. And unfortunately, that might impact a patient being non-compliant on their medications. And I think if we explain to a patient how to do it, if we give them the support, make sure they have coverage as mentioned on this slide, make sure that they have information on who to contact if they run into problems, it'll make it easier for them to continue. But I don't deny that a pill probably is, as a whole, if you take all the patients together, easier to maintain than a needle and certainly less expensive from a healthcare cost perspective. But just things to think about. I don't think we should just assume that every patient hates needles because not all of them will pick a pill over a needle. And I have patients in my own practice who literally were waiting, because I told them to wait, for the Hokusai trial to come out, booked an appointment in January of 2018 so they could see me to switch off their needles. And when I explained the results to them and showed them the graphs, they chose to stay on low molecular heparin. Not all of them, but some of them did. So I don't think we can assume that a patient will automatically pick a pill over a needle. Simon Noble, who is quite a hilarious speaker if you ever get a chance to listen to him. He's from the UK, and he is a palliative care specialist and a cancer-associated thrombosis physician. Published some great data looking at just quality of life and as well as patient preferences. And one of his studies looked at just objectively surveying patients on anticoagulation with cancer-associated thrombosis and asked them what is the most important thing to them. And by far and away, number one, at least weighting about half of the amount was that it doesn't interfere with their cancer treatment. And I think as a well person with no major medical problems, I don't even think about this. I don't think about chemotherapy side effects and how that might impact my anticoagulation or the other way. But as a cancer patient, of course, they feel that they're a cancer patient and that they want their cancer to be treated appropriately, and they don't want anything to interfere with that. And so we may not recognize that as doctors, that this is something that patients will rank very highly. And then, interestingly, number 2 and 3 were efficacy and safety, which is something that I think we sometimes ignore. I read an entire New England Journal of Medicine article, kind of not quite a full review article, but an answer to the Hokusai trial that literally said, well, if the patient wants to accept a higher rate of bleeding, then go forth and multiply. And I don't know if that really is the best message to be sending out there, because clearly patients value safety as a big thing in their treatment. And my patients certainly would confirm that. And bleeding is not a fun thing to happen, and they hate it when they're bleeding. Even if they get a bruise, they're very concerned, and they're worried that something bad is happening to them. So I think we should not assume that they don't care about safety. They just want a pill, because the route of administration came in at number 4, under safety, efficacy, and not interfering with cancer treatment. So we should word our things appropriately. Doesn't mean that we can't, encourage a patient who's appropriate for an oral drug to be on it, but I don't think we should be biased in how we present this information to our people. So I think this kind of leads into the final couple of slides, introduction to how we came up with our algorithm. And we're really trying to balance out, I mean, I think we all sat there and wished that the Hokusai SELECT trial were slam dunks, that either it clearly showed that the drug failed, like warfarin failed against low molecular weight heparin, we could close the door, or that it clearly showed that they were the same in terms of effectiveness and safety and or better, and we could start switching everybody over to direct oral anticoagulants. But unfortunately, because there were certain nuances and differences between the two sides that sometimes favored one and sometimes favored the other, we now have to think a little bit harder. So if we take a look at the paper, which I think is, first, ISTH guidelines. So I was trying to think ahead what the next slide was. ISTH did come out in about half a year ago with their own set of guidelines. A couple of the people on this committee were actually part of the algorithm as well. We have, thankfully, a lot of good Canadian representation internationally for thrombosis as well. So I won't go through line by line everything that's on the ISTH guidelines because they're similar in what they're recommending to what we were recommending in our Canadian consensus guideline. But really the summary is looking at making sure there's no contraindications to either side and certainly stressing as well that there's nothing wrong with low molecular weight heparin, so we should not be mass switching people over to DOACs without thinking of the consequences for some of these patients. And certainly they did highlight again, as we will highlight, that certain types of cancers we should be very careful about because of the bleeding rates. So this is a paper. Some of you may have seen it already. As you can recognize, there are some people, including Sadiq, who are on this paper. I was thankfully participating in this, and I'm grateful to have that opportunity. Dr. Carrier, who is one of our upcoming, if not currently one of the cancer-associated thrombosis experts of the country, is on this paper. And Agnes Lee, a lot of you may recognize her name as the PI of the CLOT trial and the CATCH trial, and currently probably the cancer-associated thrombosis expert of the world. We're part of this algorithm. So I think it's a pretty good paper. I suggest that you take a look at it, read through it. There's some good information in there. On this presentation, I'm happy to answer questions after. Obviously, we really only show the algorithm part. I know it's slightly small font, but I will go over briefly, box by box, what this showed. So the first step is really obviously to find an indication for anticoagulation, confirming they have a clot. It's a cancer-associated blood clot. Again, highlighting but that both incidental and symptomatic proximal DVT and PE can be included into this. Then to assess the bleeding risk and specifically pulling out those risk factors that I mentioned, including low platelet counts or creatinine clearance that's low, use of antiplatelet therapy, recent surgeries, and various other things. And the more and more risk factors and the higher and higher the risk, we're suggesting that you consider low molecular weight heparin at least until those risk factors are addressed and a patient becomes more well. And then if you're considered to be overall non-high risk, then we think about the type of cancer. And that really leads, again, back to the GI cancers and the urothelial cancer patients because they are at higher risk of bleeding. I can't guarantee based on the data that we have now, because these are all acute phase VTE and relatively recently diagnosed and treated cancer and or actively treated cancer, what would happen if a patient had a blood clot a year ago and has been on treatment on low molecular weight heparin for a year and not bleeding? Can you switch them, even if they have a GI cancer in the background, can you switch them now? Or if they come off chemotherapy or now their cancer is under better control and they're on maintenance therapy instead of more aggressive cancer treatment. I can't answer those questions with evidence. I can say that in my personal practice, I have let a lot of people off the hook and onto oral anticoagulants, even including warfarin back in the day, if they were less active from their cancer perspective or their clot perspective, depending on whether they had contraindications or not. And I think a lot of cancer-associated thrombosis doctors have done similar things. If a patient is now potentially appropriate for an oral drug, we may switch them off. But in the acute phase, we don't know if a patient is going to bleed or not. You don't know if they're going to do well on an anticoagulant. If they have these high-risk cancers like GI and urothelial cancers, we are recommending that you consider low molecular weight heparin first for these cancer types. If that's ruled out and they don't have those cancer types, then the drug-drug interactions, and hopefully you have a pharmacist that can help out in your center. If you have no pharmacist or no internal medicine or hematology or thrombosis, which unfortunately smaller centers may not have access to all of these, I will always reiterate again that using low molecular weight heparin first is never going to be wrong. First of all, for edoxaban, you had to use it first because that's the way that it's made, to use 5 days of low molecular heparin first. But even for rivaroxaban, apixaban, whatever else you might think you want to use, because the efficacy and safety were the same in the first few months of treatment, you would never be wrong to start with low molecular heparin first if you're not sure if there is a drug interaction or some other issue that might prevent a direct anticoagulant from being used safely. And then our world is smaller and smaller nowadays. You can pick up the phone, you can call someone, or you can read around it or find a pharmacist later and rediscuss the case and then make a decision later, even if it's a few days, a week, a month, however much time it takes for you to reassess the patient before you move on to the next steps. Because drug interactions, I find, are a difficult thing, and you may not be able to decide that right there on the spot in your clinic if multiple drugs that the patient is on. But if you do find that a patient really doesn't have any major drug interactions and they're not high risk for bleeding, they don't have GI and GU cancers, I think it's very reasonable nowadays, current evidence that we have, that direct oral anticoagulants can be a very real choice for a large number of our cancer patients. But it does require reassessment. I like to reassess people every 3 months. We did recommend this at a 3-month interval, especially if they're still on active cancer treatment, because again, things change. The doses change, the drugs change, their regimens change, they stop treatment. And so I think it's not a bad idea to see these patients reasonably frequently until their cancer is deemed stable or no longer active. And of course, if they're cured of their cancer, that's the bottom part of this algorithm where we suggest there may be a consideration to stopping anticoagulation unless they have another reason to be anticoagulated. So I know it's a lot of information, but I think we've come to our last slide, and I'm happy to spend as much time answering questions as you need. I think because there's so many options now, and again, there's no slam dunk win on either of these drugs, it does take a little bit of thought to consider all of the bleeding risks, the clotting risks, and the patient's preferences, financial issues, and so forth. And I think if we do that thought process, we can tailor these drugs to the best patient, and hopefully with this, these new drugs out there, we will allow patients at least to maintain their treatment with a bit more adherence. So thank you for your time, and again, I'm happy to answer any questions.
Great. Well, thank you, Dr. Wu, for a great review of the recent evidence in cancer-associated thrombosis, which has really changed our practice in many ways. I am going to open it up to questions, and I would just ask that people unmute their telephones and ask their questions, and I'll try and field these to Dr. Wu. I might start it off with a question, though.
Sure.
One major factor in choice of anticoagulants in patients with cancer-associated thrombosis is coverage. And this is a very sticky issue because in most provinces, provincial plans will cover the direct oral anticoagulants, not edoxaban in most provinces as of yet, but hopefully soon, but only for 6 months. And I believe most provinces are, sticklers for that. So just asking, just in your practice, does that factor into your decision-making process at the beginning of treatment? Just knowing that in 6 months they may not be covered for a direct oral anticoagulant, and they may have to switch to another drug given the importance of continuing anticoagulation as long as the cancer is active. And what do you do at 6 months in a patient who is on a direct oral anticoagulant?
Yeah, that's unfortunately a very good question and something that comes up all the time. And I can't say that all my colleagues do what I do, but I will always tell a patient that their coverage will run out at 6 months, benign or cancer. Some patients manage to finagle some more coverage by calling their insurance representative. We have Blue Cross. It's called Blue Cross in Alberta. I don't know if it's the same as every other province. And sometimes, somehow, they complain enough or talk to the right person and they manage to get more coverage, or at least 80% coverage. But I tell patients that that's not the common situation, and most people will lose their direct or anticoagulant coverage at 6 months. And not even 6 months from the time you start, but 6 months from the time the blood clot was diagnosed in Alberta. So you're losing some time if you started on low molecular heparin first. So some patients will choose to be on a direct oral anticoagulant anyways, if that's the appropriate medical choice, and then decide what they're going to do at 6 months. I've had some people who have unfortunately had to switch back to low molecular heparin because that bizarrely is covered by our Blue Cross, even though it's 10 times more expensive. We have attempted to write letters that literally state you are covering low molecular heparin, which this patient is on, and it is more expensive than a direct oral anticoagulant, and in the cancer-associated thrombosis world, low molecular heparin is superior to warfarin, and so we're not going to switch this patient to warfarin, which is cheaper. Please continue to cover. And those letters have sometimes actually been successful. I have to admit, unfortunately, in my experience, less than 50% of the time. But you make that effort, you might be able to save some patients some money and the ability to continue their direct anticoagulant. And so I think just advocating as much as you can. I think if your governing body, ours is Blue Cross again, gets enough letters from enough people that are stating this, maybe some policy changes will happen at some point. They'll recognize this as a thing. I'm also hoping that at some point these drugs will become generic. I know that's a long time from now for some of the drugs, but they may become cheaper and then more widely covered. There's no really good answer. I never try to use coverage to make my medical decision, but I will tell the patient about coverage. So from a personal preference perspective, if they can't afford it, obviously, then at least they know and they have the options of either switching and switching back or remaining on something they know is covered and not having to worry about it.
Great. Thank you. So I'm going to open it up and see if there are any questions from the group. Just unmute your phones. And just while we're waiting to see if there are any other questions, just another question about a very thrombogenic cancer, pancreatic cancer. We do know pancreatic cancer from the data you presented has very high risk of DVTs and PEs above other cancers. The trend, at least, the non-statistical trend, but the trend to better efficacy with the DOACs, does that sway you for patients with pancreatic cancer? In the algorithm that we published, we didn't talk about risk of thrombosis as much as risk of bleeding. But does that make a difference in your decision-making process?
So, because the curves did not split early, I'm really suspect about these efficacy benefits. I know that it's all hypotheses at this stage, but I truly believe, again, that if one drug was superior to another drug, you would see that superiority in the time period when it should count the most, which is in the first month to 3 months. And that's not where we saw the efficacy in either trial. We did not see the efficacy curve split at the beginning. We saw it split later. And so to me, it seems more likely that it was related to the maintenance of the drug and patients coming off therapy too early. So I would argue that it's not that low molecular weight heparin is necessarily better in terms of efficacy. They look the same. So I would argue that you don't have a skewing of benefit to the DOAC for these highly thrombogenic patients, in my mind, that would convince me that I would pick that over low molecular weight heparin for a pancreatic cancer patient. Bleeding rates, though, unfortunately, would include the metastatic cancer patients, high-risk patients, GI cancer patients, and so you might have a safety downside to starting it. But in the long term, for sure. I can say everything I want, being someone in a tertiary care center that has access to thrombosis clinics, cancer-associated thrombosis clinics, that I can counsel my patient properly, set up their coverage and so forth, and teach them how to self-inject. But a lot of places don't have that, and they may not even have appropriate access to compassionate supplies or anything for patients. And if it's very difficult to maintain injections because they are more expensive and cumbersome for a patient, and we have these oral drugs, at some point, if a patient is stable, I would not have a bias against switching them over to a direct anticoagulant to maintain their therapy. I just think that the evidence, in my mind, does not suggest that one drug is actually better than the other. Just one's easier to maintain.
That's great. Thank you. Thank you. There is a question from the chat board from Karen. I'll just read it out for you.
Sure.
None of these drugs are approved for this indication by Health Canada. How much of a difference does this make?
Good question. So I have yet to see Health Canada, at least or not necessarily Health Canada, but the provincial bodies that do the coverage, for example, refuse a patient on the basis of cancer. They will just cover the first 6 months. So I think from a coverage issue, it's the same. I have, again, into Blue Cross written letters specifically saying the patient has cancer. For Edoxaban, they refuse outright because it's just not covered at all yet. But for Rivaroxaban or Apixaban, I know there's no trials published yet, but if we had a patient on Apixaban and we sent these requests through, again, not that we have a 100% success rate, but it seems like some patients are successful, even clearly stating that they have cancer, and we're using it for cancer-associated thrombosis. So from a coverage perspective, I think that the governing bodies seem to not care whether Health Canada is specifically an indication or not. I think it's because in the product monographs they didn't specifically say we're excluding all cancer patients from this. So I think that is a bit of a gray zone in terms of what you would interpret. I do mention to people prior to these clinical trials coming out, and not necessarily from a Health Canada approval perspective, but just from an evidence perspective, that we should always be cautious about using new drugs in very high-risk patients, so either bleeding or clotting or both. And so this would include cancer patients, it would include antiphospholipid antibody patients, patients with 6 blood clots in the past, or, it's not something else that would suggest that they're higher risk compared to the average person until we know better. And I think with the data that's come out, I don't think people were very shocked that we had a drug that could work at least on par with low molecular weight heparin, but for reasons that I wasn't as shocked, but I think a lot of people were shocked that there was a huge difference in bleeding. And I think without the clinical trials and not knowing that, a lot of people might be exposed to the potential downsides of medications without understanding the balancing forces. And some later kind of more recent evidence in a completely unrelated field of antiphospholipid antibody syndrome would suggest similarly that particularly for the very high-risk patients, that there's a high breakthrough rate of arterial thrombosis on rivaroxaban versus warfarin. So I think for these high-risk patients, Health Canada or not, we should be cautious about using them before the evidence is mature. But I think right now, approvals, the approvals are there for a reason. The guidelines are there for a reason. If you or your institution or a specific doctor doesn't have the time or interest to keep up with the evidence, then they have to rely on these things, which I think is reasonable, because someone has vetted the evidence at some point when Health Canada approves things and it makes it into guidelines and coverages and so forth. But if we keep up with the evidence ourselves and we kind of keep in touch with whatever the latest trials are, we might be able to make those decisions ahead of the guidelines catching up. Is the bottom line. But if you're not sure, I always recommend you go with what you know, so that you're doing the right for the patient, and then asking the questions later and adjusting therapy as necessary based on what you learn later. I don't know if that answered your question, but I hope it did.
Oh, thank you. And one more question from the chat board. Do you have advice when a patient on active chemo and a direct oral anticoagulant have thrombocytopenia or their platelets drop?
Yes, actually I had a patient this week that I recommend to go on to low molecular weight heparin for this exact reason. So it's interesting because we don't really know what the clinical trials did. Both trials had some specific parameters on what to do with low molecular weight heparin if thrombocytopenia occurred during the trial. There were some exclusion criteria that if your platelet count started at less than 50, you were just excluded, so you couldn't yet enroll in the trial. But if your platelet count dropped below 50 during the trial, there were some parameters on what to do with low molecular weight heparin. But there were no parameters one way or the other on what to do with the direct oral anticoagulants. So you don't actually know what people did in those situations. I do know that it makes me nervous if a patient is going to drop their platelet count to 15 in the middle of their chemotherapy to be on a therapeutically dosed medication that has a longer half-life than low molecular weight heparin and cannot be adjusted as easily or at all in some situations. And so if there is a clearly predictable, very low platelet nadir that's going to last for a week or so, which is usually roughly how long these things last before they recover for their next round of chemo, I personally would use low molecular weight heparin and then dose adjust. And I know the dose adjustments are expert opinion as well, but there are some guides that are out there, both from ISTH as well as some Canadian consensus guides that would support dose adjusting low molecular weight heparin if the platelet count is less than 50 and holding low molecular weight heparin if it's less than 20. And because the half-life is so short, it makes it better to do that. So when you do hold it or decrease the dose, the residual effect goes away quickly. Whereas for a direct oral anticoagulant, it may take a couple of days before all of the drug is out of the system. So if you are trying to hold the medication or decrease the dose or whatever to mimic what low molecular weight heparin has been doing, it's still more difficult to be sure that you're safe for that patient. If the platelet count is going to be above 50, so it just drops from 150 to 80, then I would just move forward with whatever anticoagulant is appropriate, because I don't think a moderately low platelet count is going to make a big difference. But if it's going to be significantly impacted, then I would prefer low molecular weight heparin.
Great. And thank you very much. I'm going to just see if there's any other questions from the group. Again, just unmute your phone. Great. Well, with that, I'd like to thank Dr. Wu for an excellent overview of the latest evidence. And I will now turn it over to David for some closing comments.
Well, thank you, Dr. Wu and Dr. Shiva Kumar, for your great participation tonight. Thrombosis Canada appreciates your delivering this program. I also want to thank all the participants for joining us tonight, and I hope that you found this discussion useful. The program will be archived and available on our website in the next few weeks. And on the screen, you can see the link to get to the publication that Dr. Wu referred to that the presentation was based on. And if you want to get more details on it, you can go there. Thank you again for your participation, and have a good evening.
Thank you.
Thanks a lot.